All right, guys, get into chapter 29, trauma systems and mechanism of injury. Got a lot of information here to cover. So trauma is a primary cause of death and disability between ages 1 to 44 years old. So a lot of different things are going to kind of help you to analyze and help you manage your patient's injuries. Basic concepts of the mechanics and biomechanics is mostly going to help you do that. So, being able to analyze a trauma scene, that's going to be a vital skill for you as a paramedic. And you've probably noticed that as you've grown kind of in your EMT status, you're recognizing things differently, you're seeing scenes differently, you're expecting particular injuries, and you find yourself, you're more correct than you used to be when you think you see a certain kind of damage and you might expect this particular injury. So, when we talk about writing reports and we talk about giving a report, and one of the things you might hear is, we want to paint a very vivid picture, a very clear picture for the emergency department. Well, this is where a lot of that comes in, because basically you are the eyes and the ears of the emergency department physician. So maybe you work for a place that you take some pictures and you're able to show the doc what you see, but in the event you're not at one of those places, because from what I found, most of the docs don't really care about the picture you're showing them anyways, you need to be able to describe and tell them in somewhat detail with very good accuracy of what you saw. So your patient history, that's really the only source for physicians to understand the events that led to that trauma. So, it's pretty important that you're able to do a good job in this. So injuries that occur when an external source of energy affects the body beyond its ability to sustain and dissipate it. So, what it's saying is if the body is not able to absorb it and it breaks or cracks under pressure, that's when we start to come in with trauma. So different forms of energy produce different kinds of trauma, as you can expect. Mechanical energy, you're talking about energy from motion. So basically think about like two moving vehicles colliding. Chemical energy that's released as a result of a chemical reaction. So basically an explosive or even maybe an acid that causes that chemical reaction, some burning. Thermal energy that's transferred from sources that are hotter than the body. So, pretty obvious that's some of that, but flame, some hot water, steam, obviously. Electrical energy, so electrocution or an energy strike. And then even barometric energy, so a sudden radical change in pressure. So we get kind of some more extreme things here, but scuba diving, even flying, we start to see all these different types of trauma. So biomechanics, what we're talking about when you might hear the word biomechanics, that's the study of physiology and mechanics of living organisms using tools of mechanical engineering. So that can be used to help analyze the mechanism and then the results as well of trauma. Moving down to kinetics, study of the relationship among speed, mass, direction of force, and physical injury caused by these factors. So, by knowing this and understanding some of this can be used to help predict, particular injury patterns, as well as just the history that you've gathered up from your time on the job. Factors affecting types of injuries. So the kind of injury sustained, that'll be determined by the ability of the patient's body to disperse the energy delivered. Remember, when we talk about trauma, it's always about energy. It's about the body absorbing the energy or how much energy was transferred into the body from the vehicle or from the velocity of the projectile or whatever. External factors that determine the types of injury include force and energy. So size of the object delivering the force, the velocity or how fast, the acceleration or deceleration, so how fast the object speeds up or slows down, and then of course the body area of the body area affected by the application of force. Then you see the next point, duration and direction are also important factors. So the larger area of force dissipation, the more pressure is reduced to the specific spot on the body. So, obviously if you have a small bullet versus running into the wall, then the way the energy is dissipated is going to be completely different. Blunt trauma, it's a spreading of the impact without breaking the skin. And those are pretty, hard to diagnose. Often little external damage. Position of the victim at the time of the event is another external factor. So seatbelt use, versus unrestrained. So seatbelts have reduced lethal injuries by keeping victims in a much safer position than they have been in the past. So moving on, factors affecting types of injury. So the impact resistance of body parts has a bearing on the types of tissue disruption. A lot of this is often determined by what's inside the patient's organ. So meaning, is it hollow or is it solid? Organs that have gas inside will scatter energy more than the liquid or solid boundaries, and that are easily compressed. So we're talking about the lungs, talking about the intestinal tract. But then liquid-containing organs, they're a lot less compressible. Vascular system, the liver, the spleen, the muscle, the muscle. And then understanding these effects of forces will help assess the mechanism of injury. So understanding this, that can help predict your most likely type of injury. Obviously, if you know somebody got rear-ended, you could potentially expect that they might have a C-spine injury, whether it's just a little strain or even a fracture. But there's understanding these things, certain mechanism of injury, we can help kind of predict, at least where the direction we need to move with our assessment. So kinetics, a lot of this is maybe kind of rough to get through, so just bear with me. We're going to push through this stuff. So kinetics, velocity, distance an object travels per unit of time. Acceleration, the rate of change of velocity an object is subjected to. Gravity, the downward acceleration imparted to any object moving toward the earth. Kinetic energy is associated with an object in motion. So this reflects the relationship between the weight or the mass of the object and the velocity at which it's traveling. So kinetic energy equals, you see the equation there. We're not going to get much into that. But the kinetic energy of when you see KE, we're going to talk about kinetic energy. So the kinetic energy of a car in motion that stops suddenly must be transformed or applied to another object. So remember that energy still has to go somewhere. You see that if you've been on the job very long, you've probably seen a lot of differences between cars just several years ago and the way cars are made now. Now, many of these modern cars have crumple zones, and what that does is maximize the amount of energy absorbed by deformation for the passenger involved. So you notice that the barriers on the side of the highway are changing to where they're splitting and absorbing that energy versus the car just stopping immediately against those barriers. There's a lot of stuff that's changing, and it all has to do with this energy and what's happening to it. So other factors that will affect the amount of energy dissipation in a crash, they include the vehicle's angle of impact, so front impact versus side impact, how the patient hits the inside of the automobile. That's going to change as well. Differences in the size of the two vehicles, restraint status and protective gear of the occupant. So we've got a lot of these different airbags, window bags, these kind of window curtain bags, and all these different things that are there to help change really kind of the energy status of the way that it's being absorbed. The law of conservation of energy. So energy can neither be created nor destroyed. It can only change form. Energy dissipation, and I'm not going to go into a whole lot of this because honestly this is not my forte, so we're just going to kind of work through this, and then if you do have questions, you're more than welcome to send them to me, and I will probably forward them to the right person, or we can both look up Dr. Google and start finding the answer to some of this stuff. But energy dissipation, process by which kinetic energy is transformed into mechanical energy. Protective devices can manipulate the way in which energy is dissipated. So let's move on. Newton's law of motion. Remember Newton had a lot of different laws. First law of motion: a body at rest will remain at rest unless acted on by an outside force. So, what we're saying is similarly, a body in motion tends to stay in motion unless acted on by an outside force. Those two things parallel each other. And if you're just sitting at rest, something is going to have to change to cause your body to not just sit there at rest. So second law of motion, force an object can exert is the product of its mass times its acceleration. So you see that equation, force equals mass, or the weight, times the acceleration or deceleration. The higher an object's mass and acceleration, the higher the force needed to make a change of course. Deceleration, slowing down or slowing to a stop, that has a rapid deceleration, dissipates tremendous forces, as you can imagine. Deceleration and acceleration can be measured in the number of g-force. So 1 g-force equals a normal acceleration due to gravity. 2 or 3 g-force equals 2 or 3 times the force associated with gravity. And on and on. The human limit to deceleration, 30 g-forces. So in a head-on crash, transferred energy is represented as the sum of both vehicle speeds. So when we talk about, as you can imagine, so think about if you're standing on the road and you got hit by a car traveling 40 miles per hour, there'd be a lot of damage. But what we're saying, that's a lot of energy. What we're saying, though, is when you have two in a head-on crash, the amount of energy is represented as both vehicles. So you have 2 cars going 40 miles an hour. Now you've just doubled that energy of that. So you can now, that's why we see so much more critical and serious injuries in those type of patients. So multi-system trauma, that describes injuries that involve several body systems. The body has a much harder time dealing with multiple injuries, as you can imagine, that involves several major body areas. So, you've got chest wall, you got some broken ribs, and then you also have a closed head injury or an open head injury. And that's what we're talking about, multi-system trauma. Generally caused by events that affect the entire body. So autoped, someone ejected, someone hit by a bulldozer or something, something that was pretty random, but things like that. Often both blunt and penetrating trauma occur. So if you suspect that multiple body systems are affected, first thing we're going to do is assess the patient's entire body. So when we've heard about getting people trauma naked, that's a good time to do that. We need to be able, if you can't see it, you can't verify that they don't have an injury there. Then we're going to prioritize the treatment of the injuries. So remember, we always start with our ABCs. So we're going to work on our ABCs, our primary survey, and then transport patients without delay. Because remember, in these situations, we've said it before, but they need a surgeon. They don't need your 12-minute scene time. They need to be taken to a surgery suite. Moving on down to blunt trauma. So blunt trauma refers to injuries in which the tissues are not penetrated by external by external objects. So these commonly occur in motor vehicle crashes, pedestrians hit by a vehicle, motorcycle crashes, fall from heights, sports injuries, blasts even when there's no shrapnel involved. Motor vehicle crashes. So there's 5 phases of trauma tied to the effects of progressive deceleration when a vehicle collides with another object. So phase 1 is deceleration of the vehicle. So the vehicle strikes another object and is brought to an abrupt stop. Now remember, the vehicle motion continues until that kinetic energy is dissipated, or I'm not sure how to really explain that. Just look that word up because I can't probably put it in the right words, but just kind of absorbed evenly, and it goes all throughout. Deceleration of the occupant. Now we're talking about phase 2. So it starts during the sudden braking and continues during the impact of the crash. Results in deceleration, compression, and shear trauma, depending on a couple of different things. Make sure, mass of each occupant, protective mechanisms, so you use seat belts, airbags, all of that, body parts involved, and then points of impact. And then phase 3, deceleration of the internal organs. That doesn't sound very good, so I'm imagining we're getting into some serious stuff here. Body supporting structures and movable organs continue forward momentum until stopped by anatomic restraints, which you can imagine that's going to probably result in some injuries. And a lot of times that's when you see tears and shearing. You see our friend there, he took a little smack to the noggin. So the deceleration of the internal organs happened within his noggin. Then secondary collisions. Occupants hit by objects moving within the auto, loose objects, packages, other passengers even. These are known to cause some severe spine and head trauma. So if somebody has something pretty large in there and there's enough energy that causes you to stop really abruptly, those things now become essentially missiles. Then phase 5, additional impact received by the vehicle. So think about being hit by another vehicle, or it's deflected into another vehicle or a tree or an object, those type of things. This can certainly increase the severity of those original injuries, or, as you can imagine, even cause further injuries. So we'll talk about some impact patterns. How dented and deformed the vehicle looks is an indication of the forces involved and the degree of deceleration sustained by your patient. So this is pretty obvious, but think about a 50-mile-an-hour crash on the highway when someone ran into a median or ran into the back of a truck versus the 10-mile-an-hour fender bender, that you run in town. Going to be a lot of differences, and those indicate all of the force or the energy that was transferred. So the dents and the deformities on the inside of the vehicle, that'll show you the point of impact on the patient. Head injury or seatbelt marks indicate what part of the body may have been involved in energy absorption. Tire skid marks at the scene indicate whether significant injury was dissipated by braking before the crash. And then debris along the course of the crash may indicate multiple collisions and different force vectors acting on the patient along the course of the crash. Frontal or head impacts. So the front end of the car distorts as it dissipates kinetic energy and decelerates its forward motion. Passengers decelerate at the same rate as the vehicle, and then those forces applied to the driver will differ based on a number of things: car design, materials, safety features of the vehicle. And then abrupt deceleration injuries are produced by a sudden stop of a body's forward motion. So they can induce shearing, avulsing, rupturing of organs. Injuries are often invisible during your exam with these kind of patients. Obviously, the head is going to be very vulnerable to these deceleration injuries, because it can cause the brain to strike the inside of the skull, which, as you know, is going to cause some bleeding, at minimum some bruising, or maybe even some tearing. So that's going to be a real problem. And one of the real problems is it may not even show up on your physical exam, but we need to be have a high index of suspicion for that. Another thing that you might find within these, that's going to be within the aorta, torn aorta. So the aorta is the most common site of deceleration injury in the chest. Often it's torn away from its points of fixation within the body, and that's going to be a real problem. So when the aorta gets sheared or torn, obviously you're going to have a probably loss of basically all of the blood volume, and then, as you can imagine, not going to be good. That's going to be probably some immediate death. So we don't want to do that. Internal organs that continue their motion after the motion of the body stops may result in tearing or shearing injury. So you have a lot of different things that can happen here. We're talking about the liver, the kidneys, the intestines, the pancreas, the spleen. Those are all things that can have this some tearing or shearing done to them. And our last bit, crush and compression injuries. They're a result of forces applied to the body by things external to the body at the time of impact. So these are often caused by dashboards, windshields, the floor, heavy objects falling on the body or one of its parts getting trapped between two objects. So that's going to be pretty bad. All right, had a little glitch there. Okay, had a little glitch there. A lot of problems going on. We're going to get this fixed, though. Let's move on. So we're talking about, just got through talking about the crush compression injuries. So we are going to move on to compression injuries of the head. I'm sorry, my notes do not follow this. So let's just move on here. Frontal or head-on impacts, unrestrained occupants usually follow one of two. So we're looking at one of two trajectories. That's going to be the down and under pathway, or it's going to be the up and over. So down and under, we're talking about when the driver, passenger, whoever occupant, he slides under the steering column or the dash, his knees hit the dashboard, and then the energy of the deceleration is transmitted up into the femur, to the pelvis, and the upper torso continues forward until it impacts the vehicle. So not a really good thing there. Some of the things that you might think about, might be looking for, fracture or even a dislocation of the knee, hip and pelvic fractures, hip dislocation, spinal injuries, rib fractures. As you can imagine from dashboard injuries and that kind of movement that you're doing, some pulmonary and potentially cardiovascular injuries. Then moving over to the up and over, as you see at the bottom, you see the leading point of this impact is going to be the head. So the head impacts the windshield, the roof, the mirror, maybe the dashboard, but it can include significant head and cervical spinal trauma, as you can imagine. I mean, you can see his head hitting the windshield there. We've probably all seen these type of crashes. Ejection is possible if the windshield doesn't stop the body. And then a dangerous lung injury can occur if he reflexively takes a deep breath before the impact, and we're going to talk more about that later. And then lower leg fractures could also be present. So those are going to be our two frontal or head-on different trajectories or paths, down and under and up and over. So then we're talking about lateral or side. So it imparts the energy to the near side occupant directly to the pelvis and the chest. That's not a good thing, is that energy ends up going through that person directly. So seat belts, they offer very little protection because they're designed to limit forward movement, not side-to-side movement. Now we're seeing those side airbags and stuff that are going to help probably a lot more with this. But so as the passenger compartment deforms, the head can strike the impacting vehicle or the object, and then we can have injuries from the direct trauma to the affected side or tension that's developed on the far side. So, you have that whole ball of energy that's moving through, and it creates a pretty big path and can really cause a lot of damage, obviously. The rear impacts have the most survivors if driver and passenger are properly restrained. These are kind of our most times we see whiplash and those kind of things. That sudden forward accelerating force causes the body to move forward, but not the head. So head gets snapped back and then moves forward. Energy is imparted to the front vehicle. Now here in that picture, you're probably looking at a little bit more than a whiplash injury, but kind of what we're thinking about, the way I'm describing, is a little bit more of a whiplash injury. And then rotational or quarter panel impact. So occurs when a left lateral crashes off center. So the vehicle's forward motion stops, but the side continues in a rotational motion. The point where the vehicle's greatest loss of speed occurs is where the greatest damage to the occupant will occur. And occupants tend to receive frontal and lateral injuries. Moving on to rollovers. As you can see, patient can be ejected. That's going to be bad and has struck hard against the interior of the vehicle. And then, as you imagine, ejection really increases the chance of death. And what they found out through some research and statistics is it increases the chance of death by 8 times. Restrained versus unrestrained. Seat belts stop the motion of any automobile occupant who is traveling at the same speed as the vehicle. So they limit the contact of the occupants with the interior of the vehicle, as well as they prevent ejection. And then associated injuries include some cervical fractures, neck sprains, because it's holding the body in tight, but you still have that movement of the head forward, backward, so you can start to have a lot of different injuries that way. Airbags, they've reduced deaths in direct frontal crashes by 30%. You do have some secondary injuries. If you've ever been in a crash with an airbag, probably got some burns, as well as having that thing hit you. That's quite a shock. It pops out of there pretty hard and can really get you good. Motorcycle crashes. Any structural protection afforded to victims is derived from protective devices worn by the rider. So that's a really big sentence. What we're saying is the only protection you have is what you have on. So whether it's leathers or a helmet, all of those type of things. Obviously, the helmet is going to protect the impact force to your head, as well as transmits the impact into the C-spine. And then leather protects against road abrasions, but it does not protect against blunt trauma. So when assessing the scene, attention should be given to the deformity of the motorcycle, side damaged, the distance of the skid, deformity of stationary objects or vehicles, extent and location of deformity in the helmet. That's a really big one there. Once again, we talk about energy, but that allows you to know how much energy was transferred, because those things are really built to take a good shot to protect these guys. So 4 types of motorcycle impact. We're just going to kind of breeze through them, but you got a head-on impact where he strikes another object and it stops its forward motion. You also have the angular impact. Motorcycle strikes an object or vehicle at an angle. So sometimes they might sustain a direct crushing injury to the lower extremity between the object and the motorcycle. And then, then we have ejection. Rider will travel high speed until stopped by a stationary object. So severe abrasions down to the bone can occur. And then laying the bike down. Technique used to separate the rider from the body of the motorcycle and the object to be hit. So just laying her down. Helmet should be removed carefully if airway management techniques cannot be performed with the helmet in place, and then if it does not fit snugly to the head. So the helmet could be cut if it cannot be removed without further deformation. So if we're unable to get that thing off and maintain C-spine, then we need to go ahead and cut it. Hopefully we're going to not need to do airway management, but in the event that we do, then that's how we're going to handle that. Pedestrian injuries. Almost 85% of pedestrians are struck by a vehicle's front end. So adult injuries are generally lateral and posterior. They tend to turn to the side or away from the impact. And then children, they face forward into the oncoming vehicle. So we have 3 predominant MOIs, or mechanism of injury. First, impact. Auto strikes an adult body with its bumpers. Creates a lower extremity injuries, particularly to the knee and leg. Second impact, the adult is thrown on the hood or grille of the vehicle. So that results in head, pelvis, chest, coup contre coup. Remember, that was when the brain gets rattled forward and backwards. Traumatic brain injuries. And then third impact, the body strikes the ground or some other object after it's been subjected to a sudden acceleration by the colliding vehicle. So pediatric patterns of pedestrian injury, they're quite different from patterns in adult, as you can imagine. Number 1, you have a much smaller body, as well as number 2, what we talked about a second ago, which was the adults typically tend to turn and children face forward. They don't have any idea what's about to happen, so they're wanting to see what's going on. So you do have this Waddell triad, which is a pattern of injuries in children and people of short stature. So the bumper hits the pelvis and femur instead of the knees and the tibias. The chest and abdomen hit the grill or low on the hood of the car. So you've got everything from sternal and rib fractures to abdominal injuries. The head strikes the vehicle and then the ground. So skull and facial fractures, facial abrasions, closed head injury. A little bit different, that's the Waddell triad. Falls from height. So a couple of different things. Fall produces acceleration downward at 9.8 meters per second. So the severity of injuries affected are, of course, going to be by the height. The height will kind of determine how fast or the speed of the fall. Height plus stopping distance predicts the magnitude of deceleration forces. And then the position. So that'll determine the type of injury sustained and the likelihood of survivability. Children tend to fall head first, and as you can imagine, that results in head injuries, injuries to the wrists, upper extremities. Adults usually try to land on their feet. So if you've ever heard of the Don Juan, I don't think this has the picture now, it has the Don Juan syndrome, or the lover's leap. That's a group of potential injuries from a vertical fall to a standing position. So someone hopping off of a roof onto the yard because they were the old Don Juan as the fancy little romantic guy. Foot and lower extremity fractures are kind of what we can expect. Hip, acetabular, and pelvic ring and sacral fractures. Vertebral compression and burst fractures. Vertical deceleration forces, and fractures of the forearm. So then one of the other things that can be impacted by the area, the larger the area of contact, the greater dissipation of force. So obviously if you fall flat laying on your back, you're going to probably sustain less injuries than if you fell on one foot. So if you lifted your other foot up and you landed on that heel, all of that energy gets transferred into that one little spot versus almost breaking it up evenly. And then the surface, obviously, the degree to which the surface can deform under the force. So essentially thinking about if you're landing on sand off the monkey bars, or if you're landing on concrete, that's also going to help dissipate these forces. So think about this. If the surface does not conform, meaning it doesn't shape around the body, then the body will shape around it. So something is going to give, essentially, is what we're saying. And then the physical condition. So if they have, osteoporosis or some kind of pre-existing medical conditions, that's going to predispose you to fractures a lot more than someone without that. Penetrating trauma. So penetrating trauma involves a disruption of the skin and underlying tissues in a small focused area. So rather than a big, large area, we're kind of talking about penetrating trauma being in that small focused area, usually caused by maybe a firearm or a knife or other device. But they're classified in a couple different ways. Low velocity, medium velocity, or high velocity. So low velocity caused by sharp edges of objects moving through the body. So, you could think about a knife or something like that. Medium and high, usually a bullet. The path of the object might not be easy to predict because it might flatten out or tumble or even ricochet, depending on a lot of different things, the mass of it, what the round is made of, as well as what caliber of bullet it might be. So in the United States, the most common sources of penetrating injuries are firearms. And in 2013, 33,636 people died by gunfire in the United States alone. So the severity, when we talk about stab wounds, depends upon the anatomic area involved, as you can imagine. If you're talking about like getting a knife in the heart versus into your pinky finger, that's obviously going to kind of make the severity dependent upon it. The depth of penetration, the blade length, the angle, all of these things. Sometimes, it can also involve a cutting or hacking type force. And neck wounds can involve critical anatomic structures, as you can imagine. So deep neck wounds can result in spinal cord involvement and cervical fracture. Moving on to gunshot wounds, severity of a gunshot wound depends on several factors. The type of firearm, so what we're thinking is rifle versus shotgun versus handgun. Then the velocity of the projectile also is definitely going to help with the severity. Physical design and size of the projectile, distance of the victim from the muzzle, and then the type of tissue that's struck. Shotguns, they fire pellets, essentially. So from half a dozen to several dozen at a time. They can induce destructive injuries at a very close range. Moving on down to rifles, they fire single projectile at a very high velocity. And they are they're created to be extremely accurate, so it's probably going to go right where the person pointed it, as long as they understand how to operate it. Then a handgun, revolver, pistol. So revolver holds 5, somewhere 10 rounds of ammunition. Pistol holds up to 17. These barrels are going to be a lot shorter, and the ammunition is typically less powerful. Ballistics, the study of non-powered objects in flight. So these are most associated with rifle or handgun bullet travel. Trajectory, the curve of the bullet's path related to how fast it falls to the earth after leaving the barrel. Just the way some of these things work, the air, it creates drag on the bullet as it moves through the air. So that starts to affect the trajectory. Also, the bullet's shape contribute to its stability in flight. So the most important factor for seriousness of wound is the type of tissue involved. Depending upon where someone was struck and what type of tissue has been hit, it's going to determine a lot of the seriousness of it. So tissue of high elasticity, which is muscle, it's better able to tolerate some stretching. Entrance wounds characterized by effects of the initial contact and implosion. Skin and tissues are pushed in, cut, or abraded. At a close range, tattoo marks from the powder burns can occur. At closer range, burns can occur from the muzzle blast. Deformation, tissue destruction is based on density, compressibility, missile velocity, missile fragmentation. Projectile crushes tissue and creates a permanent cavity. So it could be a straight line. It could cause it to be an irregular pathway as well. But you are going to get some expansion of that pathway of where it's traveling. Essentially what that is just that tissue is being displaced and causing kind of a cavitation type thing. Temporary, could be permanent, depending. So exit wounds, they occur when the projectile's energy is not entirely dissipated. So whenever it still has enough energy to continue to travel, then it will go right out the back of the front of wherever it entered. Shotgun wounds, result of tissue impact by numerous projectiles. Remember we talked about has what's the word I'm looking for? Pellets. Has multiple pellets, so that's those numerous projectiles. That's what we're talking about. They have lots and lots of pellets, depending upon what type of round it is. Wounding potential depends upon the powder charge, size and number of pellets, as well as the dispersion of pellets. So how did they go into the body, and how are they traveling through the body? So some of that's determined by the range, at where it was fired, barrel length, the type of choke at the end of the barrel. So some of the things that we want to try to obtain, we want to be able to find out what the weapon was used, of course, what range, what kind of bullet was used. Some of the things we want to look for powder residue around the wound, entrance and exit wounds also. Moving on to blast injuries. So primary blast injuries, that's the damage to the body that is caused by the pressure wave generated by the explosion. So think about concentrated pressure. It results from that air being displaced and heat originating from the center of the blast, and that's what's actually causing those primary blast injuries. Organs that are generally affected is lungs or eardrums or any other compressible organs. Close proximity to the origin of the pressure wave carries a high risk of injury or death. And, that pressure wave is very powerful, obviously, and can cause a lot of issues. So explosions from a bomb start at the center and they move outward. Explosions from fumes or dust involve the entire area and have a no safe region. Moving on to secondary blast injuries, these result from being struck by flying debris. So objects can travel a great distance, as you can imagine, and be propelled at tremendous speeds. So depending upon depending upon the explosive is really kind of what you're looking at as to how fast things can travel. So a military explosive, things can travel up to 3,000 miles per hour, secondary to a military explosive. So can have a real issue from there. Blast wind occurs as a shock wave applies force to air molecules, and then flying debris may cause blunt and penetrating trauma. And then the tertiary blast injuries, that occurs when a person is hurled by the force of the explosion or blast wind against stationary rigid objects. Occurs when ground shock, you have physical displacement of the body when the body impacts the ground. And then resulting injuries are numerous, may be blunt and penetrating. Not sure how to pronounce that. We'll just call it quaternary blast injuries. They occur from the miscellaneous events that occur during an explosion. So everything's from like burns from hot gases or fires, respiratory injuries from inhaling toxic gases, Crush injuries from, everything from the collapse of a building or whatever, or even the risk of entrapment. So you have a lot of different injuries there that could be inquinary, caused by biological, chemical, or radioactive contaminants added to an explosive. So thinking about dirty bombs. So you kind of have your pattern here with, you can see in the center, primary blast injuries are the injuries due to the blast wave itself. So as you think about this, if you're up close to where you're going to get hit by the primary blast injury, you have all of these other things moving as well. So not only do you have the blast wave or the pressure that comes through from the blast, but then you also have the things that are being projected or propelled. You also have, once the body either gets hit by something or it hits the ground, and then everything such as whatever, if you were up close, you could potentially get burnt. I mean, you have a lot of chances for some serious injuries in this type of deal. Physics of an explosion, not my forte, so we're just going to get through this. When a substance is detonated, it is converted into large volumes of gas under pressure. Propellants are explosives designed to release energy relatively slowly compared with high explosives. Blast front, so components of a blast shock wave, you get the blast front, which is the leading edge of the explosion pressure blast wave. Then you have a positive wave pulse, phase of the explosion in which there is a pressure front higher than an atmospheric pressure. And then shock wave, which is high explosive blast waves, as well as a negative wave pulse, a phase in which pressure is less than atmospheric pressure. So speed, duration, pressure of the shock waves are all affected by these things. Size, the nature, the distance from, presence or absence of reflecting surfaces, a lot of different things. Explosion is more damaging in closed spaces, as you can imagine. A lot more damage that can happen. And then blast pressures cause destruction at interface between tissues and between tissues and trapped air. Tissues at risk. Air-containing organs are more susceptible to pressure changes. So when we say that, we're talking about kind of the heart, the lungs, blood vessels, middle ear, the GI tract. Junctions between tissues of different densities and exposed tissues are prone as well. And then really the ear is the most sensitive to these blast injuries. Your tympanic membrane can rupture at pressures of about 5 to 7 psi above atmospheric pressure. So it doesn't have to be a large blast to have some tympanic membrane damage. So they might complain of ringing in the ears, pain in the ears, some loss of hearing, even maybe some blood in the ear canal. So we're talking about primary pulmonary blast injuries occur as contusions and hemorrhages. So they could certainly have some pain in their tightness or pain in their chest, some tachypnea or other signs of respiratory distress. Subacute air, remember that crackling under the skin over the chest. Typically, a lot of times we think about that, it indicates maybe a pneumothorax, even some pulmonary edema. So if there's any reason to suspect lung injury in a blast victim, you need to go ahead and give them oxygen. One thing we want to make sure that we do is to, if we're able to, I messed up there, right there, is to avoid giving them positive pressure. So they're not going to want that in the event that we believe that there's a chance that they have a pneumothorax. We don't want to do that. So also, if they do have lung injuries, we might be really cautious about your fluids, your IV fluids. That could be a problem. So solid organs may be injured by secondary missiles or a hurled body. Neurologic injuries and head trauma are the most common causes of death. So things hitting a person in the head or them getting thrown and landing on their noggin. Extremity injuries are very common, as you might expect. Assessment and management. So if scene safety cannot be ensured, evacuate, assess for other hazards. General impression as you approach. Breath sounds frequently We definitely want to look for some DCAP BTLS, start thinking about that stuff. Baseline pulse ox value. Do not assume the absence of an abdominal injury based on the absence of overt signs. So just because you don't see any damage to their abdominal cavity does not mean that they do not have any abdominal injuries. Remember that pressure wave and those things that happen within there. And then, manage impaled objects according to the guidelines. So remember how to take care of an impaled object. We're going to make sure we stabilize it and not remove it or anything like that. So scene size up, when we're talking about, So when we're talking about general assessment of trauma, we have a lot of things that we need to be able to process. So remember that one of the things that you need to remember is very few trauma injuries can truly be stabilized on scene, because what they more than likely need is a surgical suite. So we'll move on to scene size up. Remember, PPE always going to be required. Definitely want gloves, protective eyewear. If you're able to wear helmets in a blast zone, all of those kind of things. Anticipate your possible scene hazards. So go ahead and get assistance if you need it. Assess your environment carefully, and then consider whether you'll need additional medical resources. I'm assuming if we're talking about a big blast or something, you're probably talking about a number of patients, so you probably are going to need additional medical resources. Get your general impression. So keep that mechanism of injury in mind. Consider whether spinal immobilization will be necessary. Evaluate the patient. So think about this just follows our I won't say algorithm, but more of a flow chart of our assessing a patient. So we have our general impression, and we're going to determine, consider whether we need to immobilize our spine. We're going to see if they're alert, if they're verbal, if they respond to pain. Then we're going to do a primary survey. So our A, B's, and C's, airway and breathing. If they're unresponsive, open the airway. If necessary, remove the foreign objects and suction if you have to. And then you might consider an oral or nasopharyngeal. Once the airway is clear, assess breathing, note the skin color, observe chest wall movement. So with all these things, these are quick little points, but this is doing a lot of big things. So when we're looking at skin color, we're looking at a lot of different things, because we know that for proper skin color, we know perfusion has to be happening. It means they're onloading and offloading oxygen. There needs to be enough blood to be able to do that. So we're noticing a number of things by just doing these few little points. Looking for chest wall movement, we're hoping to see good equal chest rise and fall. We're going to look for a deviated trachea, tension pneumo, crepitation, crepitus anywhere, neck and chest, broken ribs, sternum, other problems, that are going to inhibit their breathing. Then circulation. Move on down to our C. So check radial and carotid pulses simultaneously. Of course, if there's no pulse, we're going to start CPR. Skin condition can be a good indicator of circulation. We know that's a really good indicator of perfusion, circulation. So we want to scan for significant external bleeding. Do a quick, blood scan. We move on to our D. Remember, we've added a couple. It was just ABCs. Now we've got a D and we've got an E. So our D is we're going to assess for disability. So evaluate the GCS. So we're going to note the pupil size, equality. We're looking for Pearl. We're going to look for PMS. And then we're going to expose, our E. So we're going to quickly expose them, scan for life threats, and then manage those life threats as we find them. Then we got to make our transport decision. So, what we've done essentially in this 30 seconds, 45 seconds is, or hopefully it's not much longer than that, maybe a minute or two, the most, is we have determined sick or not sick. So hopefully we know by this time whether we need to transport them emergently or not. Somebody that was in the middle of an explosion, if that's what we're talking about, but we've got a lot of other injuries here, car crash, penetrating trauma, whatever, then may not need it. But altered mental status, A, B, C problems are going to be immediate transport. Multi-system trauma is probably a good idea as well. So still talking about our transport decision. If they need immediate, continue your assessment en route. On scene time should be limited to that 10. So we've probably all heard of that platinum 10 because we want to keep it within that golden hour, that 60 minutes. That's what we're hoping for. After the first 60 minutes in shock, the body has increased difficulty compensating. That's not where we want to be. We don't want to really kind of put them behind the curve here. So in our history taking, nothing new, getting our sample, OPQRST if we're able to, allergies, meds, all that stuff that we're aware of. And then two major groups of trauma, isolated or multi-system. So isolated injury, it's that one little stab wound to the palm of the hand versus somebody getting ran over. So that, with a stab wound, that allows us just to focus on that main problem. Multi-system, we're going to be looking at a lot of things and probably just really honestly working on our A, B, C, and C's. Vital signs get you a good full set, as I've said in the past. I would ask that you do it manually, and then you should get that should include your pulse, your respirations, your blood pressure, physical exam, your head to toe, all that stuff. Start looking for things. DCAP, BTLS, of course. Here's all the things we're going to be looking for. Nothing different than what we've already talked about when we went through our assessment. So we're going to start doing lots of palpating, get our hands on them, start pushing around, seeing if things hurt. Moving on down to our reassessment. So while we are en route, we're going to perform another rapid full body scan. We're going to repeat that primary survey, reevaluate our vital signs, and we know the standard. We're going to say this guy's serious or critical, so we're going to repeat his vital signs every 5 minutes. Then we're going to look to see what we've done. So if we've put them on O2, or has their SpO2 increased? What about, maybe has their end-tidal CO2, has it changed? Has their color changed? Or maybe we gave them an IV. Has their blood pressure changed? Has their color changed? All those things. Obviously, want to notify the hospital staff as soon as possible. All right, let's move on to the trauma score. So trauma scores are often used to determine the injury severity in the healthcare profession. So, there's several different systems, and depending upon your own system of where you're at, your own protocols and your own EMS service will determine upon what you use. But it's used to determine the likelihood of the patient survival. That's what we're looking for. So we're talking about here is calculated on a scale of 1 to 16. 16 is the best possible score. So it takes into account their GCS, takes a respiratory rate, respiratory expansion, systolic blood pressure, their capillary refill. So GCS is an evaluation tool used to determine the LOC. We know that scores are assigned for eye, verbal, and motor, EVM, 4, 5, 6. So if the best you can do on eyes is 4, verbal is 5, motor is 6, but it doesn't accurately predict survivability, especially with patients with severe head injuries. So, in these instances, the revised trauma score is used. So you've got a couple of different these different trauma scores. So revised, used to assess injury severity in patients with head trauma. Heavily weighted to compensate for major head injury without multi-system injury or major physiological changes. So some of the things that you use, your GCS score, your systolic blood pressure, and then your respiratory rate. Highest score is a 12, and then the lowest is 0. And this is also used to predict survival in patients with severe injuries. Here's a little bit of the information. This is in your book. Management of trauma. I think this is one of our last big pieces. So management requires an accurate assessment of the patient and knowledge of the mechanics of injury. Remember, quality of your assessment usually dictates the quality of your care, because if you're not doing a good assessment, you're going to miss things, and your quality of care will probably not matching, will not be very good. So during transport, begin any necessary interventions. And, if we need to do IVs, we're not going to mess around on scene with a major trauma. With a priority 1 trauma, we're not going to mess around on scene with these guys getting IVs and all of that. Most trauma patients will need to be treated for shock, so that may include establish an IV, administer fluid bolus, rapid transport. Unresponsive trauma patients most likely need an advanced airway placed. I'm trying to find out where I'm at here. No, let's just carry on. Several techniques can be used, so you want to use a team approach whenever you're trying to manage trauma. You want to be able to have more hands on deck than really what you need almost, so everybody's doing something. And then critical thinking is going to be very important. Without critical thinking, you're pretty much useless, in my opinion, in EMS, because it is such a big part of what we do. You see, we talk about consider fluid resuscitation. I may have skipped over that. Consult with your medical control. So you see, begin fluid resuscitation at volumes that maintain a minimum. 90 is a good minimum, 100 is a good minimum, depending upon what research and what curriculum you read. What happens there is if you give a lot of fluid, like is what we used to do, which was start 2 16-gauge IVs and hang a liter on each person. And what you start doing essentially is watering down the Kool-Aid. So you basically start diluting the blood, and all of that fluid that you're putting in there, all that water essentially, is unable to carry O2. So it's really of no use. All it's doing is making the heart work harder, as well as it's blowing out all of the clots that are forming. That's 2 problems. One is now you don't have those clots, which you needed. And the second thing is you have microemboli now that are free-flowing and going all over the place, which can really be a problem, as you imagine, within the body. So this can all be some real problems. So we want to just, a term I believe this book uses, I know our last curriculum did, but it's a term that you'll hear within EMS, and that's permissive hypotension. So we're saying it's okay for them to be a little bit low on blood pressure because the heart's not having to work as hard. We're not blowing out the clots that are trying to naturally occur and form, as well as we're not watering down the Kool-Aid, which is a really important deal. So moving on, trauma lethal triad. So we've got a couple of things in this triad. Let's call it the triad of trauma. Hypothermia, so being cold. So even, make sure we don't go, So even mildly hypothermic patients, they have a lower survival rate than normothermic patients. So the problem with that is that contributes to coagulopathy, which essentially is just poor blood clotting. That's going to be a problem in somebody that has multiple bleeds. So we don't want to do that. We don't want to interfere with that blood clotting process. Number one, we're going to cause much greater blood loss, and ultimately probably death, because we're going to have a lot of poor perfusion going on. So, and then the coagulopathy. So, like we said, so the hypothermia, I kind of hit 2 points there. The hypothermia is the cold part, which does not allow the body to start clotting properly, and then coagulopathy, that is poor blood clotting. So that's a real issue. And then acidosis often occurs with excessive bleeding and treatments to compensate for it. So that contributes once again to coagulopathy, and it complicates treatment. So that's a really bad thing, these 3 things. So if you've ever, if maybe one day you'll start flying, then you'll notice that while you're flying, you have to take temperatures of all of your patients. And it used to be only trauma patients, because they've related that when they were figuring all this out, that hypothermic patients, as they were a trauma patient, was not doing very well. So moving on to, let's talk about management. So first thing we want to do, we want to aggressively seek to control all the bleeding to the best of our ability. Sometimes you're just not going to be able to. We want to keep our patients warm. We want to minimize the volume of acidic IV fluid. So remember that the normal saline is actually a little bit of acidic, okay? Now go back to your acidosis. If you're already creating some acidosis and now we're throwing in lots and lots of acidotic fluid, and it's not at a high rate, I don't remember exactly what the pH was of it, but it is acidotic, then you start to increase this issue. So we want to pay attention to that. We also want to monitor our end-tidal CO2. And then if you work for a place that uses TXA, you're going to want to go ahead and administer that. So since you've heard me say that, TXA, you might as well go ahead and get your drug card out and start taking a look at that, because there's a really good chance you're going to see 1, 2, maybe 3 questions about that coming up on a test. Criteria for referral to a trauma center. Physiologic criteria. So some of the things we're talking about is if one of the following is present, refer to the highest level trauma center. So a GCS of less than or equal to 13, systolic less than 90, and then a respiratory rate of less than 10 or more than 29. Now remember, this is not just a patient with this. This is what we're talking about if they have major trauma and then they also have a bad GCS or a bad systolic blood pressure. Anatomic criteria, a little bit different. So now we're looking for anatomically what's going on. So penetrating trauma to the head, neck, torso, extremities. That's will get you referred to the trauma center. Chest wall instability, 2 or more long bone fractures, crushed, degloved, mangled, or pulseless extremities. Sounds bad. Amputation proximal to the wrist or ankle, pelvic fractures, open or depressed skull fractures, paralysis. MOI criteria, so mechanism injury criteria, falls for more than 20 feet or 10 for children, 20 for adults, 10 for children. High risk MVC, so when you got intrusion in that passenger compartment, when everything's been pushed in. Ejection, whether it's partial or complete. Vehicle telemetry data consistent with the high risk of injury. So now everybody has a lot of people have the computerized stuff in their cars that tell that kind of things. Pedestrian, bicyclist thrown or run over, and then motorcycle crash at more than 20 miles per hour. We're on the back stretch here, guys, so hang on. Criteria, still talking about special consideration. So if none of the above are met, consider transfer to an ED or low-level trauma center if patient is more than 55, systolic is less than 110, and older than 65. Children should be triaged to a pediatric capable trauma center if the patient uses anticoagulants or has a bleeding disorder, if they're pregnant, more than 20 weeks, low-impact mechanism in older adults, burns with other trauma, or the EMS provider judgment, which is just that gut feeling for you that says, man, I've been kind of on some calls like this, and I truly believe this guy's going to go downhill. That gets you a ride to the priority. That's a priority 1 patient as well. So that gets you headed downtown to OU or wherever your facility is. So you've got 4 separate levels of trauma center. 1, 2, 3, and 4. It's important to know which hospital specializes in, and then you can start filling in the blanks. So neurology, burns, pediatric trauma, cardiac cares, microsurgery, hyperbaric therapy. So you need to know who you're going to take in burns. In the city, it's going to be Baptist. Neurology, sometimes they do a little rotational thing, but you need to know who's going to take each kind of thing so you can go to the right place. Here's your key elements for your trauma center. So you see that the differences between level 1 and level 2. Not a lot of big differences between level 1 and level 2, but there is. A lot of it has to do, from my understanding, when you really break them down, it has to do with research, as well as I think being associated or affiliated with a teaching hospital. But level 2s get a lot of really sick people and really broken people and are doing good work there. Mode of transport. So when making the decision to transport by ground, several factors should be considered. So can the appropriate facility be reached within a reasonable time frame? What is the extent of the injuries? If it's in a congested area, can the patient be transported to a more accessible landing zone for air medical transport? So remember, when you're going to load a patient, maybe you're not in a good spot, but you're always able to move. So, you can always move to a football field or to a big parking lot at maybe a strip mall or a shopping mall or even a church. Criteria for use of air medical services. So extended period required to access or extricate. That's always been one of the big ones that we use. So if someone's trapped, it's going to take them a little bit of time to get them cut out. That's a good time to get a helicopter there, because the second that guy comes out, you're able to load him up into the helicopter and off they go. Distance to the trauma center is greater than 20-25 miles. Remember, a lot of this is going to be dictated by your own services protocols as well. Patient needs ALS and no ALS ground. Ambulance service is available. Traffic conditions, lots and lots of traffic. If it's going to make, really mess your time up, then go ahead and call a helicopter. And multiple patients who will overwhelm resources at the trauma center. So, if you have five 5 critical patients and you've got 4 ambulances, or if you are going to take one to a different place and you need to hit them in all kinds of different places, just good to have a helicopter available. EMS systems require the patient be brought to the nearest hospital. Criteria for air medical. And if there's a mass casualty incident. So if you're working in a system that says, no, this patient has to go to this particular hospital, and that is not a good hospital for them, that would be one as well. So some of the things you need to consider when we start talking about transport decision, you consider your ground transport time, make sure that's reasonable, and then the time it'll take for the aircraft to lift off, travel, and land, load your patient up, and do the exact same thing and get back. So sometimes those are going to be a wash, so you might as well just go ahead and get your patient to the hospital, and then it leaves that aircraft available for another call. And then the terrain, of course. If it's not good solid terrain for a helicopter, if it's uneven landing or they're unable to land in certain areas, then that's not going to be a good time for a helicopter. Research. Military has done extensive research over the years over mass pants. Determined that they were found harmful, even though they were used for a lot of people. And I've heard a lot, never used them myself, but I've heard a lot of good things about them. But from what I think they were used, I think this might be kind of one of the things that's going on right now with intubation, which is, I think it's a very valuable skill, but I don't think we do a very good job of managing it and do a very good job of training on it and the accountability standard. I believe this might fall into that same kind of thing, because from what I understand, there were a lot of people saved by these, but what would happen is they would have to be taken, the pressure would have to be taken down from these mass pants little by little by little. These were called anti-shock garments. So you would have to take the pressure down to allow the body to compensate and everything. And what were happening is they were just taking these pants off people very fast, and the body was just, everything was getting blown out, and the body was not able to compensate, and they would croak. So that's probably not a good thing. So they got rid of those. And I'm not sure that's necessarily the interventions issue, or if it's not the care providers issue. But another thing that we're seeing, tourniquets, those have become very popular and have proven themselves very useful. When I first got into EMS, they had just gotten away from tourniquets. So we see these things kind of come back and forth. But only evidence-based treatments should be adopted for widespread use, not this anecdotal evidence where, this makes sense or I think this would work, but we need to be more evidence-based. And I believe the evidence-based stuff is what's going to help further our profession, as well as it just makes sense. I believe we are at the end. So that is chapter 29, Trauma Systems and Mechanism of Injury. I know there was a lot of science-y kind of stuff, and that's not my deal. So I appreciate you sticking with me, and we'll talk soon.